Hello, my name is Dr. Staja Booker, an assistant professor at the University of Florida, and today I will be talking about my pilot project, identifying intra-racial and interracial differences in movement-evoked knee pain. Here are my funding sources. So you're probably thinking, what is movement-evoked pain? Well, simply, it is just what it sounds like. It is pain that is acutely provoked or experienced in response to active or passive movement of the involved tissues. And we see that in people with osteoarthritis, they often complain about pain during movement or walking or doing different household chores and daily activities. And we know that osteoarthritis currently affects about 30 million people in the US. And we expect this number to increase to about 67 million by 2030. So, osteoarthritis pain that emanates from movement is a leading cause of disability and decreased function and mobility. And so, one of our premises are that pain during movement is understudied, yet it's a critical component to understanding disparities in pain related disability outcomes, particularly between Blacks and whites. And that once we characterize movement evoked pain, then we'll be able to identify important intervention targets to actually reverse impaired function or prevent decline, but also to improve or reduce pain. And so I believe that it is important that we understand not only movement evoked pain, but also how do we manage and mitigate that pain. So there's a robust and kind of growing body of literature on movement evoked pain, including some recent analyses and papers coming from the Fillingham Lab. And I will talk just really briefly about a paper that I published in 2019 looking at racial differences in movement evoked pain and psychological contributors. So we examined movement evoked pain between Blacks and whites. And ultimately, what we found is that Black participants with knee osteoarthritis, fewer people reported that they had no movement evoked pain or zero movement evoked pain. African Americans reported nearly twice as much movement evoked pain as whites. And consistent with the literature, they also demonstrated lower function in different activities, including things like gait speed and ability to stand from a chair. And so we also wanted to see how perceived stress or some type of psychosocial factor influence movement evoked pain differences between Blacks and whites. And we found that even though their perceived stress scores were comparable, perceived stress was more strongly related to movement evoked pain in African Americans than whites. And that just kind of gives us some preliminary evidence that perhaps movement evoked pain is not only driven by biological factors, but also psychosocial factors as well. So this kind of led me to the pilot project was to really explore interracial, which means between Blacks and whites, as well as intra-racial within the African American population, differences in movement evoked pain. And today I'm going to focus on aim 2, which I try to systematically quantify movement evoked pain and function during different standardized activities. And so I measured pain during movement during several different activities, including pain during walking on the gait right electronic walkway mat, during the biodex, which is a common device that they use in rehabilitation therapy, as well as climbing stairs and standing unassisted from a chair. And I'll quickly just kind of summarize this table, which gives the average pain scores before, during, and after each activity in each of the three groups. And so we recruited 28 Blacks and whites who were 55 years of age and older, and the average age was 66 years of age. And so if you kind of just follow along this table here, you'll see that one of the trends we noticed was that the baseline pain in African Americans was higher for every movement evoked task. The other thing we noticed from the pain scores was that certain tasks, such as stair climbs and chair stands, Blacks demonstrated a unique pattern wherein their pain decreased during the task and increased after the task, which is kind of unlike the pattern that we saw in whites, wherein their pain increased linearly. And so I think one of the interpretations from this is that Blacks have a greater propensity for greater pain facilitation and lower inhibition and even greater pain summation, which kind of gets at some biological mechanisms. And then one of the third things that we noticed is that particularly for the biodex, the largest increases in pain intensity were noticed between baseline pain and pain during the biodex. So Blacks increased by 2.33 points and whites increased by 2.12 points on the numeric rating scale. And we also noted that the rate of decrease was higher in whites. So when we looked at before or baseline pain to post pain, which indicates that pain increases and decreases at different rates in Blacks and whites, which also kind of gives some credence to my previous comment about pain facilitation and pain inhibition. So I'm going to focus, for the sake of time, only on the biodex. And so what we looked at here was how function was related to select demographics. And what we found was that sex was predicted peak torque during flexion on the biodex, wherein males had greater peak torque than females. However, the pain intensity scores were not, none of the pain intensity scores of the biodex were significantly related to this function. Okay, and then when we looked at the biodex during extension of the knee, we found that males and people at younger age had higher peak torque. And just so you know, when I talk about peak torque, that's really talking about knee muscle strength. And what we also found was age was significantly related to function during peak torque. And that kind of makes sense. You know, younger age, you have better functioning of the knee. So then when we looked specifically at race, we found that peak torque only during extension at angular velocities of 90 degrees and 180 degrees was significantly higher in white cases and Black controls compared to Black cases. However, we didn't see any differences in peak torque during flexion of the knee. And so what can we kind of conclude or surmise from this research? One, of course, that there are racial differences in how people experience pain during different movements between Blacks and whites. But it also kind of shows us that movement-evoked pain is an emerging model of pain measurement that may lend some insight into really just the overall pain experience of older adults with knee osteoarthritis. And really by isolating pain with movement versus pain at rest, we're really able to kind of tease apart and understand what is contributing to arthritis-related limitations in function and mobility. And if we can improve or reduce the pain during movement, perhaps more older adults will be able to maintain their independence and functioning as they continue to age with this chronic condition. And so some research implications, you know, I have a K23, which is specifically looking at intra-racial differences. So only African Americans with movement-evoked pain, and trying to phenotype that movement-evoked pain and identify biopsychosocial predictors that perhaps we can target to reduce movement-evoked pain. We also need to think about incorporating movement-evoked pain as a patient-reported outcome measure, since we know that a lot of people typically report more severe pain or that pain is aggravated when they do become active and move around. But also one of the things about looking at movement-evoked pain is that it moves us a little bit closer to more precisely kind of measuring and assessing pain. And so when we think about perhaps bringing people into a clinic who have chronic pain, perhaps instead of just asking them to rate their pain or reflect on their pain, maybe we have them get up and walk down the hall, observe how they're functioning, observe their gait, and then also ask about pain while they're walking. And that just kind of gives us more sensitive information about pain and how we can go about um, mitigating that pain. And so, of course, some of the clinical implications is perhaps maybe it's time that we transform the way we understand pain and kind of shift away from a static measurement of pain into looking at more movement-based pain assessments in clinics, in the hospitals, etc. And these are just a few papers here that kind of are moving us in that direction. And so again, if you have any questions about any of this work or would like more information or you want to collaborate, feel free to reach out to me by email. I'm also on Twitter. And I like to end my presentations by just saying that pain in African Americans impacts the nation. Thank you for this opportunity.